glad you asked me that. Let me tell you what I learned today. Let me tell you what I was taught today. So, as I've been doing in each group, I'm going to ask you 3 questions. I'm going to ask you, who's ready to learn? You're going to say, I am. I'm going to ask you, she said, I know it now. I'm going to ask you, who's ready to grow? You're going to say, I am. And I'm going to ask you, who's ready to win? And you're going to say, we are. Guys, I want to be able, with this last group, give you the logic behind that. So when it comes to affirmations, right? My name is Wesley P. Ryan, founder, CEO of Next Level Training. And part of our motto is let's learn, grow, and win together. So 2 years ago, when mom passed away, my mom would always say, she would say, son, the moment you stop learning, that's the moment you start dying. Right. And so even with cancer, she would study and research and do all these things about her cancer and about her body. And then the growth came from, my father would say, son, never put a ceiling on what you're trying to do. There's always room to grow. And then the together, I coach girls softball. And I tell them, we don't win games as individuals, we win games together. And so these are these opportunities to where we come, where we're able to learn, we're able to dive into it, we're able to grow, but most importantly, we're able to win together. So as we're paying attention, everybody up. She looked at me like, if you asked me to stand up one more time, you knew it was coming. You knew it was coming. So here we go. Who's ready to learn?
I am.
Who's ready to grow?
I am.
Who's ready to win?
We are.
All right, so listen, honestly, I know it's a few of us, but I feel like we can be louder than that. And I want us to be able to declare and decree this for the individuals that are not here. So I'm gonna ask you again, and we're gonna finish this whole thing out, this 4th panel, on a high note, because their energy is gonna match your energy. So here we go. Who's ready to learn?
I am.
Who's ready to grow?
I am.
Who's ready to win?
We are.
Fantastic. All right, take a seat. Guys, I'm going to be introducing the amazing people that are going to be running this panel and communicating with you on this panel. The moderator is Dr. Jade Hunter Woodford. Dr. Jade Hunter Woodford is a licensed professional counselor and a licensed marriage and family therapist with a PhD in marriage and family therapy. We also have on the panelists again, back to back, and just to note, he was the only alpha that came back to back. So I know y'all saw all them Q doctors up there, but alphas, they use us throughout the whole process. They use us twice, because we are usable. That's how we do, that's it. I mean, speak for itself, but Dr. Kevin, he is a Texas licensed psychologist with a sincere passion for developing others. And we also have Dr. Monique Thompson, who has been in private practice for over 22 years. She earned her license in professional counseling over 20 years ago and worked with child survivors and sexual trauma through a contact with Dallas ISD Youth and Family. And then we also have Bree Ajay. Bree Ajay in her thriving private practice, Time to Excel Counseling LLC. She has a strong focus on fostering healthy relationships and empowering individuals. Bree has earned a reputation as a trusted therapist and a certified sex therapist. So guys, without any further ado, we're going to dive into our Mental Health Matters panel, and I'm going to turn it over to Dr. Jade Hunter Woodford.
All right. Hey, y'all. Hey. All right. So I just want to say thank you for you guys being here and being a part of this discussion. I think it's so important for us to be able to have these discussions, because I think when the term mental health, but we do all have mental health. So having these kind of conversations, I think, allows us to be able to engage in this conversation and creates comfortability, which is so important. And also is a big part of just destigmatizing this, because our mental health is a part of our overall health and well-being. So I just want to thank y'all for being here. And I won't delay us any further. Ties mental health in our community. So anybody that wants to jump in, jump right in.
I'll jump in. Okay, all right. I'm jumping in because one of the organizations here locally is called Bridging the Gap Foundation. Anybody heard of them before? Yes. Bridging the Gap Foundation is doing a lot of work to reduce the stigma, and one of the biggest efforts that they do is provide funding for therapy. So over at my booth, there is a flyer right now that says that we have an evening and weekend clinic that allows people to pay what they can afford, which reduces a financial barrier to accessing therapy. The only reason that we're able to offer such a luxury is because of Bridging the Gap Foundation. So on the one hand, there still exists the stigma of mental health and mental illness, and like if it even exists. But next is once you get over that hump and decide you're gonna access help, your next challenge is finding someone who looks like you. And their next thing is being able to what? Pay for it. I no longer accept insurance. A lot of providers don't accept insurance. And so how would you possibly pay for your services? And so that's one thing that we can do as a community is support those organizations that are doing the financial reduction. Loveland Foundation is another organization that allows people to access so many sessions, and Loveland will take care of the burden of the financial expense. So as you're looking around in your community, like what can I do? You can support those organizations that are making it possible for people to step into therapy and get the treatment that they need by reducing or removing the barrier of finances.
Yes, absolutely.
So in terms of maybe the stigma, what should be, are they being taught to say what they have? Because I don't know what that looks like. You know what I'm saying? I don't know. So if they say, you're not good for my mental health, or if they say, you're not good for my mental illness, I don't know the difference. To me, it's all the same. So for someone who's not in your space, who's just hearing these words, I'm just going to what they're saying, but they're in that space because they're getting their treatment or medication or whatever it is. So is there an effort or a movement from them, you know, even what they're talking?
I'm gonna give you a quick yes, and then I want to share. So the quick yes is yes, National Institute of Mental Health, the National Institute on Mental Illness is a resource I recommend for anyone for getting accurate information about any diagnosis. Although I know TikTok and YouTube and Instagram, they want to share information. Consider that although we have access to information, and that's a beautiful thing, expertise is still at a premium. All right. So it's one. The other organization I heavily recommend for families is NAMI, National Alliance for Mental Illness, as far as you as a family member or a friend taking courses where you can learn what you need to say, what you need to do, things not to do, things not to say. Locally, I'm not sure if they're still active, was the African American chapter of NAMI. They were active in the Dallas area. I'm not sure if they still are, but that's another option. The last big piece is sometimes you can find specific resources, specifically for bipolar disorder. I'm gonna use this one example. There is a series, Loving Someone with Bipolar Disorder is an excellent resource because it takes you through the caregiver role that you don't know that you signed up for. And it helps you understand both the illness and your caregiver role. And again, some conversational do's and don'ts, as well as some self-care that you need to consider. If you are in a caregiving role, you do have a higher issue of compassion fatigue, vicarious traumatization, and not knowing is a problem when someone actually has a diagnosis. So when we say mental illness, we typically mean they have a diagnosis. When we're talking about health, we mean that all of us have mental health and we have ebbs and flows in our quality of mental health. But sometimes a person actually has a diagnosis and they do in fact need their family and friends to be informed and aware. I'm going to share something that I only happen to know by Dr. Lambert. His mom shared earlier about the importance of the family getting into a support group, even if the person won't go. This is her direct quote. And she said, if you're in that group, you're going to learn things, you're going to find out things, and you can share that with other people, with your family member, with their doctor. So even if the person won't go, it's still important for the family and friends to go to those support groups and access those resources so that you are well educated. This is literally like what, an hour ago? His mom was explaining, like, you gotta go, you have to go, because you're not gonna ever be able to get all of this information on your own. So getting into a support group is a really big opportunity. And I'm gonna pass this on, because if I have it in my hand, I'll just keep going.
Hi, y'all. Well, I was just going to say, just making sure not to get caught up in a diagnosis itself. A lot of times you can go to your PCP and they'll say, how are you doing? And you might start saying, well, I've been feeling down, and they might say you have depression, but a lot of times that could mean that they might give you a prescription for depression. And sometimes people get really caught up. I mean, typically a diagnosis is going to be a set of symptoms that you have, right? But you don't want that diagnosis to be the overall picture. There's so many things to do. A lot of times we're like, can you tell me what's wrong with me? I'm just looking for some kind of diagnosis so I can figure out what's wrong with me. But it's like, once I tell you what's wrong with you, what are you going to do with it? Like, what are you going to do with that information? So a lot of times when you do get some kind of diagnosis, or you do some online quiz that says you have ADHD, that's information, but you really have to figure out, what am I going to do with that information once I find that out? Because it typically doesn't mean anything's actually wrong with you. You have a set of symptoms. It could be situational. People go through grief all the time and they're diagnosed with depression, but that doesn't mean you necessarily have depression. You might have some situational depression going on in that moment. And you also don't want to use your diagnosis as a crutch. And that happens at times where it's like, well, you know, I'm only acting like this, you know, I'm bipolar. And it's like, it's understandable. That is a part of you and you are going through some things. However, that's not an excuse. And are you doing anything about it once you get that information? Are you going to therapy, or are you taking care of your physical health? There's so many things that go along with mental illness and mental health, if that makes sense.
Yeah, I would say, you know, my counseling center, we do a lot of training of young doctors that are either finishing their doctorate degree or fresh out of school. And the way that I teach them to think about diagnosis is, it's sort of our doctor's shorthand of being able to describe, what am I working on? But to not think of it as a box or a label that you're putting on someone, and making sure that the patients understand that as well. But this is, you know, our way of describing, you meet certain criteria that describes like what's going on with you right now. And this is sort of the focus of the treatment that's going on. But that can be alleviated and you could be relieved of that diagnosis, especially if you're compliant with treatment. You could also be coming in for what we would call like an adjustment disorder, where you're going through, you know, a tough time in your life where the stressors are impacting you and causing you to have some symptoms of anxiety and depression, but it's not full-blown anxiety and depression. It's just due to the specific stressors that are going on in your life. And so most people would consider people that are diagnosed with a adjustment disorder as fairly healthy, high-functioning people, but the diagnosis is describing what's going on, if that makes sense. Okay, so I think for some people, having the diagnosis frees them because it's like, oh, there's research and there's data for what I'm dealing with, and I'm not the only one. And so sometimes it's very liberating. And for other people, like she was saying, it could become a crutch or a sense of they can feel condemned by the diagnosis. So we try to be very sensitive to that. And I think also when you're working with docs that look like you and understand your cultural background, they tend to be more sensitive to that as opposed to just talking about it like they would talk about it with their family and friends. So that is also an advantage of working with somebody that looks like you, or at least working with somebody that works in a shop with other people that look like you. And so my docs, while all of them aren't Black and brown, they are being informed and reminded by their colleagues of the sensitivity that they need to be considering when they're working with people that are not looking like them. Yeah.
One thing I wanted to add to that, and I know this may have not been your question, but when you are in relationship with someone who may be struggling with a diagnosis, or maybe it's something that's happening in their life, something that could be helpful is going in and doing maybe some couple work or some family work too, because when that person is dealing with it, they're not dealing with it in the vacuum. It affects the whole system. So something proactive that you can do is be like, okay, let's go talk to somebody together, because you learn more about what's going on with them. And you also can learn, okay, how can I support them appropriately? What do they need? Because they might not even know. But sitting down with someone who is trained in that and understands the system and the dynamic can help be like, okay, they're dealing with this. This may be helpful for you guys to try, or this may be something that would empower you to be able to feel like you are actually able to show up for them with where they are. So
Mhm.
I can appreciate that. Just sometimes it's, you start out dating somebody,
Yeah.
then if they have a check, right?
Mhm.
If you're dating and they start their drinking, you don't know what medications they are.
Mhm.
Alcohol,
Mhm.
weed, whatever you got going on, I don't know. And then now that's added on top of the other stuff.
Mhm.
By the time I figure that out, it's.
Mhm.
I mean, I'm just telling you.
Yeah.
That's what it looks like nowadays, when you're like my age, we're trying to think, we're trying to see, you don't know what's going on. We typically go to a restaurant first and then there's alcohol.
I'm gonna say it's 2023. And while over 20 years ago, when I started, some of our evidence-based practices were not known, were literally not known. Most are now. And we're more connected now than we used to be. There are research communities. ResearchGate is an easy one where we can go in and interact with people who are doing research on the disorders that we're treating and directly communicate with them. I was able to directly communicate with the author of a study that dealt with adult survivors of sexual trauma because I had so many questions about his results. I did not see the same results in my population, like at all, to the point where I read it a couple of times thinking maybe he's from France, right? So I finally communicated with him and we asked each other so many questions. And in the end, he wrote one word back to me. And I simply replied, yes, and thank you. And the word he wrote back was culture. And I said, yes, and thank you. And that's where we rested with the answer on why what I was seeing was so different from what he was seeing. It is unacceptable. And I'm sitting up on this on purpose. So I'm going to be transparent here. Bree, I'm on Bree's doctoral committee. I have a book on infidelity and recovery for couples. And a lot of my colleagues use their work. It didn't work. It's done really, really well. But I use a lot of evidence-based practice in that book. And that's where I'm coming with this. It is unacceptable in 2023 for your providers to not be in the rhythm of what we know right now. It is entirely unacceptable. Once upon a time, we had to wait for the journals to come out, wait for it to come in the mail. You had to be printed. Then you had to wait to go to the conference, sit through all the workshops, hope to talk, maybe get your question answered if you got lucky. But now our environments are just as connected as the rest of the world. And it is unacceptable if your provider has not come up with a way for things to be getting better. Some mental illnesses cannot be cured, but remission is a real objective for treatment. Maintenance is a real objective for treatment. And the practitioner or whoever they're going to see should have some kind of treatment plan in mind toward that end, which almost always involves family or significant other involvement, period. So some of it is that I unfortunately, I can sometimes tell the person has just been going habitually to treatment, to therapy, but not getting treatment. And there is a difference between going to just a life coach, just going to talk, and there's nothing necessarily wrong with that inherently, except when you should have been getting treatment. And the treatment follows the diagnosis, as he's saying. It's shorthand for all of us. We all know what these codes mean. We know what the person should be getting. We know when it's not reasonable that they shouldn't be at an increased level of care. And we can communicate that with each other and mean the same words. So if that practitioner doesn't have a treatment plan, what you're running up against in 2023 is somebody who is either non-compliant with a treatment plan or who doesn't have one. I hope that helps some too. They may need to go someplace else. That's all I got to say.
Okay, so we're gonna jump into the next question. So the question says, they say trauma can be passed down generationally. Why can't I say this word today? Generationally. There we go. Got it. Through genetics. What are some tips with handling generational trauma? It's the big T word.
So with generational trauma and maybe just even trauma in general, I think the first step is definitely having some awareness. A lot of times people will come to me and they're like, I had a panic attack the other day and I am not sure why. And I'm like, well, tell me a little bit. And they're like, well, my mom died and I've been fighting with my spouse a lot and one of my kids is getting in trouble a lot and I kind of have been just yelling at people. So if you think about trauma, a lot of times you're just trying to figure out where does it kind of come from. And a lot of times when we ask about family, things definitely come out. Sometimes you're kind of fearful to talk about it. And sometimes we have memories that get suppressed. Some people I ask about their childhoods and they tell me they can't even remember what actually happened during their childhoods. And when we think about trauma, our brain does certain things to protect us so we can continue to move through life. If we look through a child who has been through trauma, a lot of times their brains look different than an adult brain, because basically it kind of changes the pattern of the brain once you experience some kind of trauma. So a lot of times the first step is kind of making yourself aware that there's something that could be a block. It could be where you keep getting in relationships and maybe you're not attaching yourself or you're not emotional. And you say, why can't I actually tell someone how I feel, or how come I can't verbalize it? And then you say, well, my mom wasn't really emotional, but she was a good mom. She made sure we had food on the table. She didn't really give us hugs. She didn't say, I love you. That's kind of a form of trauma. You don't know what it's like to actually show love and being vulnerable. And that's not something, if you weren't taught, that you can just do today. It takes a lot of steps to get to that point. So a lot of times when I'm working with trauma and it starts from the family, I'm starting with trying to figure out the awareness of like, how did your family actually impact you? Also thinking about if you've been through like any physical sexual abuse, those things are really hard to actually process. And a lot of times when we're starting with trauma work, we're trying to process it and then we're trying to break some cycles. Breaking the cycle is one of the hardest things to do, because typically we're taught certain things and we're trying to unlearn it. And sometimes they say we're trying to reparent ourselves. We're trying to get the things, the comfort that we didn't receive from our parents growing up. And a lot of times working with your therapist, it takes a level of commitment. That's why you have to find the right therapist to be open, honest, and safe with. Because if you come to sit in my office today, I mean, some people do tell me their business the first time, but a lot of times it takes us really building a relationship for them to feel comfortable enough to tell me the deepest, darkest memories. And sometimes we're opening up wounds and sometimes they have nightmares and they don't even know if that really happened or not. So it takes a lot of time and it's a full process. And honestly, when working with any type of trauma, grace and empathy for yourself is always going to be the step. And then, like I said, just the commitment to want to break some of those cycles.
You got a question?
Mm-hmm.
I know that there's certain generations where we were like,
Yeah.
Feeling love,
Yeah.
saying I love you, or being totally innocent. Do you find that to be the case in any of your sessions where it was a generational characteristic thing that affected?
Yeah, definitely. I think that comes up a lot, especially as like Black women and being independent. A lot of times, especially if you had a lot of siblings, you find yourself, cooking and cleaning, taking care of your siblings. And I feel like we're almost conditioned at some point to be very independent. And so let's say that you start being in a relationship, even a marriage, and now you're supposed to be a little bit more dependent on a spouse. That's not the easiest thing to kind of let go. That means that you are going to put trust into someone else. And that is actually a lot of times what I'm kind of working with women with about like, how could you be in a relationship and still feel so alone because you're not actually depending on a partner, but then you were also raised to be very independent. And it's a really hard cycle to break. And trust, I mean, that's a trauma in itself to be like, okay, let me go ahead and just trust you and say you're going to take care of this. That way I'm not being superwoman.
Did she just threw, did y'all see she not being superwoman? She should just drop the mic, Bree, just drop the mic. Here's my answer to this. I'm gonna ask you guys, because I know most people have their phones. If you will Google this real quickly, epigenetics, okay? EPI, and then genetics, GENETICS, epigenetics. And then I want you to put in, when you can select the Google images of it, select videos. And one of the top videos probably is one on the survivors of the World War II, or there may be a video for the survivors of the Holocaust, or you may see one about rats. You see, she's like, yes, I see these things. Yes. So I want to get you to look at that later, because we already decided we're not going to leave the way we came. Okay. So save those videos, and I want you to watch those later. But so I've been at Perkins School of Theology for 21 years as a consultant. I work with the interns who are finishing up seminary. This is their last year in seminary. And what I do is, on the off week when their professor is out, I come in and we talk about mental health. We talk about their self-care and mental health. We do a deep dive on the psychological factors that are interconnected with spirituality, faith. We process all these things. So it just so happens that this week we talked about epigenetics. And I showed them some of the videos that you guys are looking at. And then I needed to instill some hope. Okay, so what you're going to see when you look at those videos later is going to make you feel a tinge of hopelessness. I'm telling you that now, because what you're going to see from those studies is that the people who went through things, the survivors of the Holocaust, had children, and those children presented adverse symptoms from things they had never experienced due to genetic changes in their makeup that was passed down to them from their parent, even though the parent was long done with the trauma. We're talking about an actual genetic change. Right. So when you look at those videos, it's going to make you feel a little hopeless, because you're like, so some of what's going on with me, I was born this way? Yes. Okay. And then I want you to look up telomeres, TELEMORES. You may add to that Google search maternal trauma. And you'll see some articles that come up about how in the womb, the telomeres that help your body to manage stress are changed in length before you were ever here, because of the trauma that the mother went through before birth. You may also see that this affects African American women at a higher rate. So now we need to instill hope. So the answer to the original question is, it's not just an emotional thing, it is an actual biological thing. Okay? And it can make you feel a little hopeless. Like, what am I supposed to do? I came into this world with this. I'm going to add just another tinge of science before we get to the hope. Many of you probably are familiar with the ACE study. So you may want to Google that, ACE, ACE study. And if you look up the NPR article on it, it'll help you look up your ACE score and understand what it means. And then there's a Black pediatrician, her name is Naomi Burks Harris, and she did a TED Talk on the ACE study to further help you understand what it means. So here's the dark truth, and then we're going to get to some hope, okay? So the adverse childhood events are things that happened before age 18, and these are just things you were exposed to. A parent with mental illness or substance abuse, homelessness, a parent being emotionally neglectful. It's a long list of things, and then you have a total score. All right. Really, if that score is above a 2, we're already heading toward risks of negative health outcomes lifelong. The higher their score, the higher the risk. Okay. But guess who the study was done on? Not people who look like us. The first study was with the Centers for Disease Control and Kaiser Permanente, with white males who were married, had families, and were college educated, and obviously had jobs because they were working at Kaiser Permanente. And since then, the World Health Organization has replicated the study, which is part of the science of what we do. Somebody has to do this study over and over again to validate the results. And this same study has been done in pretty much every country around the world, and it is consistently able to predict negative long-term health outcomes. All right. So you're a kid before age 18, right? So these are just things that happen to you. And this is your physical health, not just your mental health. All right. So what can you do? Now let's talk about health. Let's talk about the hope. One thing, as you just heard Bree say, is that you might want to just go and sit down somewhere. Get comfortable. If you see me, you can get comfortable on your own couch, because I'm halfway retired. I don't even leave the house. And I'm 100%, well, 98% telemedicine. I'm looking at Dr. Lambert, because right before we started, I was like, so you still seeing people in the office? Because I got some couples I need to send to you that want to see people in person. And I go into the office about maybe an hour or two a month at this point. I've been doing this for 22 years. Bree was outside. One of my interns was out there who just got licensed. She is intern number 15. Dr. Thompson is trying to do nothing as a thing to do. Okay. All right. Do nothing as a thing to do. But over these years, the science is beautiful to me, the things that you can do. And one of them really is just nestle up on somebody's couch and just unpack all of this, because your neural pathways, as she was trying to explain, are already there from childhood. By the time you make it to adulthood, your brain is fully developed by the time you come into therapy, but your neural pathways continue to learn throughout your lifespan. Neuroplasticity is something we didn't know about when I was coming into the field. We definitely didn't understand neurogenesis, which is brain cell reproduction. Now we understand there's so many things you can do that will help your brain to recover. Okay, but it is intentional effort. And fortunately, we are not throwing darts in the dark hoping. Like, you come to see a practitioner who's well informed, they can tell you, do this, this should help. And they're not basing it off an idea or just, an instinct. We literally are saying, no, you need to go to bed every night at the same time and sleep all night long and wake up feeling refreshed. No, that's not something I came up with. Yes, you really do need, for real, for real. Some of that came from Howard University. They did a study on sexual trauma survivors, and they compared two groups. One group was not recovered. They were not getting better. The other group was. Same treatments. Somebody decided, let's just look at their sleep patterns. And that's where the problem was. The group that was not recovering from PTSD also had initial insomnia, mid insomnia, morning melancholic mood. They were having broken sleep, which means the brain was not able to fully recover. The other group was falling asleep just fine, sleeping through the night, waking up feeling refreshed. Your brain is the one thing that tells all the rest of your organs what to do. So imagine if it's not in the best health. But if you go to someone who knows what they're doing, they can tell you lots of small things you can do. 10 minutes outside in nature alone reduces your cortisol levels. There are breath exercises that we can teach you that help you to sleep better. They help you to not lose your mind when somebody is losing their mind with you. You go on a date, you can find how to do some belly breathing to help you listen to her talking about what's going on. And you'll be like, really? Oh, okay. Check, please. All right. Seriously, I know a lot of brain tricks. Everybody up here knows a lot of brain tricks, but they're based in science. Right? So it's the dark part. When y'all look at these videos, it's not happy truth. It's going to tell you that there were genetic changes you had nothing to do with, that your long-term health, you like, so do I just die now? No, you do not die now. You get help. The doctors who were here earlier were telling you the same thing. Go get help from someone who has experience and interest in you getting better. And you can. It's 2023. I unfortunately see people, I'm sure you guys too, I see people, I'm like, I got to clean up somebody's mess. They've been in therapy for a long time. I'm like, okay, y'all was just playing every week. Seriously, y'all were just playing. They should give you possibly a refund, at least a 50% off coupon or something, because some of the things that you are still struggling with, you should have been able, seriously, even with couples, sometimes you can tell that the couple went to see somebody, they took them on a retreat out in the woods, helped them get on a zip line, and they were supposed to be magically delicious, okay, but they're not using the science. They're not using Gottman. And they see how they all know who God manipulated. See, I'm point I'm making out to you guys. There's science that we're not questioning anymore. It's like kids learn best with phonics and we're done with that science. Same thing in behavioral health science. So much of it is that, yes, there is a genetic predisposition that you come into this world with. It is unfortunate, but it is true. Yes, even if you get here just fine, before age 18, things you were exposed to change your health outcomes. That's just true. But as God would have it, your brain can still learn. My favorite quote from Nelson Mandela: I never lose. I either win or I learn. I dropped
I got nothing for that. Mm. So that's a great question. And I can piggyback a little bit on what they were talking about in terms of thinking about these sort of like epigenetics and stuff like that as like a predisposition. So your predisposition doesn't determine your future. It is simply like just, you know, we all have baggage. When we come into a relationship, we have stuff that we've been through, and it inevitably is going to impact our new relationships. And so you have to be able to know, you know, what is it that I'm bringing into the situation? And so some of this stuff has nothing to do with even you. Some of the stuff has to do with, you know, your parents and their trauma and that sort of thing. But imagine this long line of stuff that you've been dealing with and that your parents have been dealing with and your grandparents have been dealing with. And now you're trying to enter into a relationship with someone who also is not aware of their own. Should it surprise us that it's going to be a challenge? You know? And so entering into a relationship with your therapist is really not much different, because that person is supposed to be a trained professional. We're supposed to be self-aware, which is the biggest barrier to us having healthy relationships, period. A lot of times, you know, we don't examine ourselves and we're not aware of ourselves. When each of you walk into a room, you have a stimulus value, right? Where when, as a, you know, 5'11", I'm gonna say 6 foot right now. As a 6 foot tall Black male, when I walk into a room, people, and depending on the demographic of the room, right, there is going to be a response to me when I walk into that room. And how I choose to carry myself and how I engage in people, a lot of that has to do with my disposition coming into the room, as well as other people's awareness of their own disposition as to how they take me in, right? And so when you're sitting with that therapist, you're trying to get a sense of, first of all, we need rapport. We need to build a relationship. And how do they take you in? How do they begin the process of understanding what your predispositions are, what your presenting issues are, and everywhere in between? Because a lot of times my clients, they have no clue what they want to work on. They just know they're not happy, right? And you don't have to know. That's something that we're collaboratively going to discover together. I believe, you know, and my standard in my clinic is that depending on the severity of the symptoms and the situation, by 5 to 6 sessions, there should be some sort of movement. So it does take sometimes a few sessions to just establish rapport and to get enough information to understand what's going on. By session 5 or 6, there should be, you know, some things that they're able to provide for you to say, okay, here's what I've been hearing, here's what I've been suggesting. Maybe you're not following through, so that's another therapy. You know, I think any professional worth their salt, like they shouldn't be just hanging out with you and taking your money or insurance's money so they can fill their slots, you know. Also, you know, boundaries. Pay attention to the therapist's boundaries. Like, are they working outside of their competency? So, you know, that's something that I'm gonna try not to get on that soapbox, but it grinds my gears when people are working outside of their box, right? Like they have no training, or I'm interested in this, so I'm gonna take on a couple, and or I'm working with this individual, and then I'm gonna also work with their family, and I mean, I worked with their spouse and do couples. No, like find a lane, run that lane well, provide good service, right? So your couples therapist, if you're working with a couples therapist, your relationship is their client. So that is their focus. Their advocacy is for the health of your relationship, right? Imagine if I'm working with you and then you say, okay, but my husband and I are having problems. Okay, well, bring your husband in. Guess what's going to happen? One of two things are going to happen. Your husband's going to feel some kind of way because I have a relationship with you. And for however long we've been working together, I have been your advocate for what's best for you. He might feel, okay, well, he's biased because he's on her side. So it's not going to work because he doesn't trust me, right? Or I'm going to compensate and I'm going to try to bond and connect with him, and you're going to feel betrayed because you'd be like, wait a minute, you my guy, right? So this is why normally it's just, you know, there are some rare exceptions to this, but overall, it's just a lack of boundaries and a lack of an awareness of the therapist not knowing their role, right? You'll also see this where maybe I've been your couples therapist from jump, or I've been your individual therapist, but the sessions are starting to become where I'm trying to tell you about my stories and what's going on with me. It ain't about be some self-disclosure, but typically that's frowned upon to do that too much, let alone some might even argue doing it at all. Like, I don't know if I would go that far, but you have varying degrees of perceptions about that among mental health professionals. But, you know, but just where do they know the boundary? Do they know when their stuff is actually interfering with the stuff that they're supposed to be working on with you? Because they have trigger points, if you will. So I'm working with a couple, and you know, the wife is kind of emasculating the husband. And, ooh, my wife made me feel that way yesterday, and you know, well, let me help you understand. No, that's irresponsible and unprofessional. You know what I mean? But so just wanting to make sure that the clinician has background and experience and is connected to the research on the matter that you want to work on or talk about, and that they demonstrate a genuine care for you where you feel some relief after about 5 and 6 sessions.
On a practical side of this, availability, and I call this the sweet spot, meaning your calendar, when you are available, just you have a spot on your calendar does not mean that that's a spot for therapy. So when you're connecting with any of us and we go to scheduling, it's not the same as scheduling your dental appointment or your eye doctor appointment. You want to think about, do I have therapy time available? Do I have time to come in? In other words, I encourage people to have about 30 minutes available on your calendar before our session, and at least 30 minutes to an hour available on your calendar after our session. So some of it is availability. And if you know that all you have is lunchtime, then I'm probably going to say no, but I've been doing this for a long time, and it's a seasoned response to knowing that I have to sometimes tell, even though we would hypothetically work well together, the availability for the session is part of our work. So some of it is availability. The other kind of practical side of it is, even though you may be in pain, do you want to come into therapy right now? Therapy is an elective level of care. The private therapy that we do is an elective level of care. And although it may be medically indicated that yes, you probably should get treatment, and we could justify that it's necessary, but do you want to come in right now? And if it is not an increased level of care, meaning intensive outpatient, partial hospital, inpatient, residential, something like that, where you could have a mental illness warrant to make you go or something like that, then I really encourage people to think about, but do I want to go? Because you not wanting to go to an elective level of care, meaning our level, means you're probably not going to actually show up. And the homework and stuff that we assign is, I mean, all those things go into your experience for getting better. And so thinking about, do I even want to? And then a gut check. Like, I know you think there's, but really a gut check. You hang up the phone after scheduling an appointment and you're thinking to yourself, I do not, then maybe give it one session, maybe two, like he's saying, maybe one, maybe two. But in that gut check, it may be you. It may not actually be the therapist. But in that gut check, you like, this is not going to work, then it's probably not going to work.
And I was going to just make one more point. Just also keeping in mind, like when you do choose your therapist, a lot of times, like, I'm not going to like toot my own horn, but people like, I like you, you're nice. And you might say that about your therapist, like, she's really nice. Like, I think we have good conversation, but you have to think like, what was your intention and what is work you're trying to do? And sometimes work is hard. And there's times I feel like people might leave a session, if I'm holding them accountable, that they might not like me at the time. And so sometimes it creates some distance. You have to make sure when you're having that relationship with your therapist, it's not because you just like them. You guys are actually doing really good work together.
Okay, so we only have a few minutes left. So I want to wrap this up because one of the things that we've been talking about in all the sessions is making sure that you're finding practitioners that look like you. So I want to give everyone on the panel opportunity to share what their specialties are and where they can be found. You may not be taking clients, which is fine, but I think sharing that information will be helpful for the folks who are here. So
Currently I am taking new clients, but I am more so taking couples right now, as I am working more on the sexuality piece of things. If you did want to find me, I do have a website. I do still take insurance right now. I do take Blue Cross Blue Shield. I take United Healthcare, Aetna. I'm not sure how long, like, insurance can be a lot for therapists. But just as far as even finding therapists, a lot of times people don't know. Typically, if you have any job, typically they have EAP benefits, or they're supposed to. And a lot of times people don't use their EAP benefits. It usually gives you about like 4 to 5 sessions. So if you're like in a crisis and you just need to talk to someone, your EAP benefits are there. There's so many different websites. If you do feel like I can't find a therapist that I can afford, there's a website called OpenPath, and I think the max is about $40 that you would pay for therapy. Also, there's also counselors in training. She mentioned she had an intern. Typically, when you're an intern, sometimes your fee is a little bit less. If you go to a university, they have clinics that you can go to, and the sessions are about like $20 per session. And the interns are really good. So just because they're in training, don't think too much about that. But also, there's so many websites. If you type in therapy for Black girls, there's a big website that's a good network to start finding therapists. Taraji P. Henson has the Boris Henson Foundation. They actually do free therapy sessions as well. But typically, if you just do a Google search for Black therapists, there's websites like Alma, Headway, where you can just put your insurance in and it will match you with a Black therapist. So especially where we're at, I'm not sure about other places, but there are a lot of us out here, and even if I can't take you, you can ask me and I will definitely refer you to someone. I don't see children, but I know a lot of good children therapists. I'll even do the research for you to make sure you get matched with someone.
Right. I would say this literally just happened at the beginning where I was like, I have a referral. So for my couples, I try to figure out, like she's saying, what makes sense. Yeah. And I'm in the Frisco area, so I tend to send people to Osiris Wade. I'm like, he was like, yeah, I know Osiris, right? So we kind of know each other on some level. And that helps because I can think through who might be a good fit, you know? So now I have Dr. Lambert's information. I have some couples that I need to send. And so he just clicked over and gave it to me. My website is drmoniquethompson.com. I don't accept insurance, but the evening and weekend clinic is a place where people can get zero to whatever you can afford to see a therapist and get the help that you need under someone's supervision. It's Dr. Lambert was saying he has docs that he's supervising them. If you're an intern in Texas, if you see an intern in Texas, someone's supervising them by law. And that law also stipulates how often we have to see them. So it's not just kind of a casual relationship. It is dictated by law, and our license is tied to it is a real situation. University of North Texas has a clinic. The Center for Play Therapy, if you're a kid, you have a kid that needs to be seen, the Center for Play Therapy is a drive if you're on the south side, but if you're on the north side, the Center for Play Therapy is an option. If you're in DISD, the Youth and Family Centers, those are options for kids. The back of your insurance card, and it sounds so pedestrian, but call the 800 number for customer service on the back of your insurance card and say, I'd like to see a therapist. They may not, and usually will not, give you a person specific to certain ethnicities. Sometimes they won't, but it does not hurt to ask, right? So all they can do is tell you no, but you can look at other websites and find someone, and it does help. If you reach out to one of us and we can't take you for whatever reason, my rule of thumb, probably I would say most people's is 3. I try to give at least 3 names. So I hope that helps with the connection piece of this. Yes, I have some cards in my pocket. Look, past these, y'all see me after. My booth is over there I have a booth out there. I think one of the interns is still out there. Looking at my watch, she may have left. But I have a booth inside the health fair as well.
Okay. The name of my center is Great Life Counseling Center. I just gave the young lady some rack cards that have the information for our center so that you could plug into. We specialize, we have a location in Addison and another location in North Plano, right off of 121. We specialize in couples and trauma, deal with a lot of individual stuff as well, anxiety, depression, midlife crisis, all of that stuff. And so, you can go to the website, look at the clinicians, see what they specialize in and what their background is and all that. My background, or kind of jam, I like to call it, is working with couples and working with people of faith. So kind of like a pastor to the pastor. I actually worked for SMU for 10 years and actually got kind of my start with working with a lot of clergy by all of the Perkins students that would come through the health center to see me. But then it's kind of expanded since I went into private practice and working with rabbis and just people from all different types of just leaders of faith communities. And, a lot of times, these leaders don't have anybody to turn to. So that has just expanded in terms of, athletes and, a lot of these folks that just are isolated and not really having anywhere to turn to have support. And so I was going to say, as far as if you're going to use I would definitely recommend just to save some money. If if you're going to go to counseling, if you could use insurance, that would be the best route because you'd pay a copay. But even if you're not in network with someone, you can usually submit what they call a super bill. And most insurances usually will pay a pretty good percentage of it, and so you can get that back after a few sessions. You just send in the super bill and then they'll pay you back. So that kind of cuts down the cost. EAP tends to have session limits. So I would recommend that more for stuff more related to work and shorter term care. I wouldn't recommend trying to use that for for couples counseling or something that was going to probably take a while in terms of being able to see a real turnaround. there's other programs that are more longer term, like Lyra, and some of these other ones where you can go longer. And oh, and she made a really good point about the interns and the people that are like practicum students or under supervision. Some of my students, my student clinicians, you know, they tell me all the time, like, oh no, I want to see Dr. Lambert. Sorry, no offense, but I don't know if you can handle what I got going on. Think about it this way: you're getting a twofer, if you will, right? Because as she was saying, like, I'm watching and monitoring the work that they're doing. If they're in a center where there's a lot of collaboration and a lot of consultation, we're a lot of times they may want to videotape the sessions, which is the best form of supervision because it's like quality assurance. So I'm like, hey, how's that session going? And they're like, well, I had this struggle, or I don't know how they responded. Okay, pull up the bill. Let's go. Let's watch. Okay, you should have done this. I just wanted to know about blah, blah, blah. And I'm, this is what we're going to take things in another direction. So I think that even now, 20 plus years of being in the field, that, we do a thing with our team called a reflecting team, where we have a rotation, an 8-week rotation, where my team watches me or one of my senior psychologists on the team work with a case, and they're able to watch live and see us working and see us do whatever the thing is. Usually it's couples or family work and that sort of thing. But just even the feedback and the questions that the team might ask me about, well, why did you do it that way, Doc? Or what was your thoughts about da da da? Well, I read in a book that we should do this, and you did that, and that keeps me on my toes. It keeps me thinking about how I'm intentionally working on things. And quite often I'll learn something new because they'll say, well, here's what I read, or here's the latest research on XYZ. Have you thought about integrating that? And so I would definitely encourage you to keep an open mind in regards to that, but obviously you want to have a good rapport, somebody that you feel comfortable with. So those relational skills are actually hard to teach. It's the clinical that they're really growing in, but somebody that you feel like you got a good vibe and this person is invested in doing a good job, and they got a little bit of pressure because they got a supervisor that's breathing down their neck to make sure that they do a good job representing their license and their organization. So you might actually get something a little bit better because you have more people on the case, if you will. Oh, Kevin Lambert, Dr. Kevin Lambert.
Okay, well, we are wrapping up. So again, I want to thank you guys for coming out and listening to this panel discussion. I think y'all shared some really good information. So I'll hand it back over to you.
All right, guys, let's give this an amazing panel a round of applause. Also, the cards and the information, young lady here, she has those. So if you're looking for something, want to get a card, make sure you do that and gathering their information. And that is all. Thank you guys so much for being a part of these amazing panels, and for allowing me to help host and navigate through this conversation. I would definitely say I've learned a lot. And I know that I'm not the same as I came in this morning, from everywhere from women's health to breast cancer to our men's talk, and even now to mental health, and being able to be a part of that. And I love the fact of what she said. We all just a little bit crazy. And we just got to learn how to manage it and be able to do that. So, thank you for confirming that in me. My mom would say it all the time, boy, you ain't got no sense. So I don't want to say that now, but thank y'all so much. Thank y'all for being able to bless us today.